Morning viewers at home and around the world. We're happy to be back today on Health Matter. May 3rd, next Tuesday, is World Asthma Day. And the theme of this year's World Asthma Day is closing gaps in asthma care. And of course, you agree with me, to close gaps in asthma care, we ought to have a good understanding of what asthma is all about, what the disease is all about. And with me today in the studio is a colleague, Dr. Femi Omotosho. Dr. Femi, you're welcome.
Yeah, thank you very much.
He
Dr.
is a public health physician. He will be talking to us about what we need to know about asthma. Okay, what is asthma? It is a medical condition that affects the lungs, oftentimes characterized with difficulty in breathing. It can occur at any age. The major issue with asthma is that it causes a chronic inflammation that affects the windpipes. Okay, when that happens, the body system begins to produce, the airways starts to produce mucus more than it does in a normal circumstances. And with this production of mucus, it begins to occlude the airway, which is the pipe that transmits air that we breathe in and out. And when that happens, it brings about with it an increase in the difficulty that could come with breathing. And of course, you have people with asthma presenting with shortness of breath, difficulty in breathing, oftentimes cough. Asthma also is a disease that is not curable. Okay, so with us today in the studio is a public health physician that will be telling us what we need to know. It's at this stage that I would like to yield the floor to you. You're welcome once again, Dr. Femi.
Yeah, thank you, Dr. Barth.
Yeah, thank you very
for
much.
that insightful opening.
Thank you very much. So what do we need to know about asthma? And of course, how can we close the gap in asthma care?
Yeah, thank you once again, Dr. Barth. Yes, as you rightly said, every year, the first Tuesday of May, every year for the past almost 2 decades now, we've been celebrating what we tag the World Asthma Day. And basically, what this is aimed at is to increase awareness about this disease to the populace and even among healthcare practitioners and in communities generally. So because basically looking at the theme for this year, closing gaps in asthma care, this is basically targeted at the 3 core areas in which asthma generally affects. First, we look at the patient's perspective. Yes, we know when we talk about asthma, without the patients, then there is no asthma. So patient perspective is the first major area that we look at in terms of closing the gaps. And secondly, we look at the healthcare personnel. In taking care of patients, obviously we need healthcare personnel. When we talk about healthcare personnel, we are talking about all category of healthcare workers, ranging from doctors, nurses, pharmacists, all to everybody that work in the healthcare system, and also looking at the healthcare structure. And thirdly, and also very importantly, the community, very important. So those are the 3 core areas because the community talks about the patients, right from the patient's closest ones, the family, the relatives, and then the general area in which the patients live. So for these 3 core areas, those are the areas in which forms the summary of closing the gaps in terms of asthma management or asthma care globally. And as we said, this is not a local thing, it's an international celebration which we do annually. So for this year, starting from next week, which for excited from this weekend, we keep on talking about asthma in terms of helping us to close the gaps across these 3 major areas, as I've said, in terms of patients, in terms of the health personnel, and also the community. So for these 3 general domain, we now have, for this year, we have about 10 targeted domains in which we are looking at in terms of how we can close the gaps. But for the purpose of this discourse this morning, basically, we'll be looking more at the patient perspective because I believe most of our viewers are, yes, the patients, and also looking at the community perspective in terms of what do patients need to know in terms of asthma, and also what do the community in terms of the family, the people in this that form the support system for patients with asthma, what they need to know about asthma. There are several things that we need to know in such a way that we are able to provide adequate care for patients with asthma. So I think as we go along, we'll get to discuss more of these things. And one major thing in terms of the domain that will keep on resonating in terms of awareness for the public is this year is that asthma is a chronic disease and not an acute disease. So I think we'll talk more about that as we go on.
Thank you very much. Thank you very much for that elaborate description of what asthma is all about. Now, we do know oftentimes people begin to wonder what causes this asthma, okay? And of course, what are the types of asthma? Sometimes we'll see little children coming down with this problem very early in life, okay? It has actually happened to a family member of mine, okay? And are there really risk factors, or asthma? Does asthma have known causes, and is it curable? We have this belief that oftentimes someone can overgrow it as time goes on. Probably a child that has asthma much longer, as the child grows, it could disappear. How true is this?
Yeah, thank you very much, Dr. Barth. So, very valid questions. I'll first start with what is the cause of asthma?
Yes.
As we know, for us in the healthcare space and also for our general public view, there are some conditions that we specifically, that's the disease state that we know the causes, that we say, okay, this is the cause. While there are some conditions that we don't generally know the cause, and we will say the cause is idiopathic, meaning the cause is not known, but we know the risk factors. So asthma falls into that category of disease in which the cause is not known, in terms of you can't say this is a particular thing that is causing asthma, as in a particular, either a microbe or so the cause is idiopathic. So generally what we have is, we have risk factors, associated factors that we know can predispose an individual to asthma. And so when we talk about asthma, it's more of looking at the genetic makeup of the individual. So asthma could be familial, meaning it could run in families. And that's one of the commonest risk factors in which we know. And asthma also, apart from running in families, could be related to exposure to the work environment, especially in adults. So, but basically, what we should know is that asthma is a chronic condition. Mostly, it could be familial, and it has its genetic composition. So, it's not because maybe it's due to a particular, for example, if you're looking at malaria, which is a common disease, we know the cause. It's caused by mosquito bites. Infected, a mosquito that has Plasmodium falciparum. But for asthma, there's no particular one cause. It's a multifactorial thing. It has different risk factors. And so we can look at the risk factor. I've talked about the fact that it could be familiar. That's one of the strong risk factors, meaning it runs in families. So for example, if your great-grandfather or great-grandmother has asthma, there's an increased likelihood that your father will have it, and there's an increased likelihood that you yourself could have it. So that's one is a risk factor on its own. Then if your body makeup also has some genetic predisposition to some asthma symptoms. For asthma, we have some things, some symptoms that correlate with asthma. For example, allergic conditions. So some people who are naturally predisposed to allergies could also have that increased risk of having asthma or asthma symptoms. And that's looking at, yes, from birth. But even outside that, for somebody who is not doesn't have that familiar history, over time, exposure to some environmental factors, another we talk about occupational exposure, because we know occupation is it's a situation that exposes us.
And of course, there's occupational asthma.
Yeah.
Okay.
Occupation is a situation that exposes us to different hazards. So if a particular occupation exposes an individual to hazards that could affect the respiratory system, then that person could start having symptoms of what we call occupational asthma. So ab initio, early in life, you may not have symptoms of asthma, but you see that as the person grows up, you start having such symptoms, and then you need to
Thank you very much. So in other words, there's allergic asthma and non-allergic asthma. Yes. Okay, we are going to go on a short break. Please go nowhere. We'll continue from where we stopped. I would like to open the phone lines for viewers at home and around the world. You can reach us to make your contributions. The topic today is closing the gap in asthma care, in asthma management, in asthma treatment. And of course, with me in the studio today is a public health physician, Dr. Femi Omotosho. Dr. Femi, you're welcome once again. Yeah, now, before we went on that short break, I was going to ask you, or I asked a question, can asthma be overgrown? This is a very controversial question. I usually see patients coming in to tell me that they had asthma, but along the line, it disappeared. How possible is this?
Yeah, thank you very much. Very apt question. As you said, earlier when we started this discourse this morning, we established the fact that asthma is a chronic illness. It's a chronic disease. And as I said before, this is one of the domains that we are trying to close the gap, even as we are celebrating World Asthma Day this year. It's one of the areas in which we are trying to communicate to asthma patients and also their caregivers, that's the communities, their support system, that asthma is not an acute disease. It's a chronic disease. And for us, as you know, once...
And by chronic, you mean
long-lasting
or lifelong. Thank you very much.
Asthma usually will not be outgrown. But let me clarify this, because people will tell you, yes, but I've seen patients, or I've seen people that, yes, earlier in their years, they had symptoms, and as they grew, the symptoms actually abated. Yes, and that's actually the goal of asthma management. Asthma can be controlled, which is the goal, which is the trust of management now worldwide. Asthma can be controlled. And when asthma is controlled, you will not even know the person has asthma. And that's why people tend to say, I've outgrown my asthma. Let me give us a typical scenario so that I can bring it home. For example, now, I have a patient, an adolescent, maybe at 15, was diagnosed with asthma. And initially, in the first few years, they're having difficulty managing the asthma. But over time, they became adherent to their medication, using their inhaler therapy. And the patient became very stable, well controlled over the years. The patient using his or her medication for years. And maybe at age 30, the patient is well controlled using his medication. And the patient feels he or she is doing well, even if not on medication. But that doesn't stop the fact that same patient keeps on living till 40 to 50. But the issue is there are some trigger factors that usually trigger those symptoms. If that patient at 40 is exposed to any of those trigger factors and is not controlled and is not on medication, at that age of 40, the person can have those symptoms. So the person will tell you that, but I thought I've outgrown the asthma. So asthma is a lifelong disease. So, but it can be well controlled in such a way that even while living to elderly age, you won't have any symptom.
Sorry, let me pause you a little. John from Delta, good morning. Good morning, Mr. John. Are you there? Okay, thank you very much. I think we lost that caller. Please do call us back. We are still here with you. Now, that takes me to the next question. We also have seasonal asthma. A whole lot of people discover that their asthma gets worse during the season. I would like you to throw more light on this. Why is it so?
Yes, thank you very much. Yes, talked about seasonal asthma.
What has changed?
Allergic asthma.
Yes.
So, you know, when we started this call, we said there is no particular known cause of asthma, but we have what we call risk factors. So, another thing for asthma is that asthma care for patients, the trust now is it should be individualized, because the risk factor for patient A would not necessarily be the same risk factor for patient B.
Ditto for the triggers.
Yes. So as you rightly said, seasonal asthma, there are some patients that react to different seasons. There are some patients that it is during the cold seasons that they will have frequent symptoms because they react to the different allergens in the environment during that period. While there are some that it doesn't have to be cold season, either cold or hot season, they will always react.
Yeah. Sylvester, good morning, sir.
Morning.
Yeah, how are you today?
I am fine. And you? Thank you.
I'm good. We'd like to hear from you.
All right. Please, I have a question to ask.
Go ahead,
Doctor.
sir.
Yeah, the coordinator of that program asked an initial question. And that initial question is not answered. He said, that whenever the thing is in a child, can the child overgrow it? And that question is not answered. I am interested in that question.
Okay, thank you very much, sir. He will repeat the answer now. Just hang on, sir. You'll hear from him. So go ahead, Dr.
Yeah, thank
Femi.
you, Mr. Sylvester, for that question. I think we talked about it just before you called. So we've said it. Asthma is a chronic illness. So it is not usually overgrown. It is lifelong. But children or adults can live their normal life having well-controlled asthma. And what that means is that when we talk about well-controlled asthma, they live without the symptoms, or the symptoms come in maybe occasionally, once in a while. Asthma can be well-controlled, but asthma usually is not cured, is not outgrown, no. But patients can live well, normal life without symptoms. So it can be well-controlled, but not outgrown.
Thank you very much. Thank you very much. Now, still on asthma in children, I understand that 10 to 12% of children in the U.S. are affected with this problem or this disease. And of course, it has been on the increase. What could be the reason for this increase in the number of cases we see in asthma, not just in the U.S., on a global level, in children? What could be the reason?
Yes. Yeah, thank you very much. Yeah, you are very apt today. So,
Well, before you take that question, let's take David from Lagos. Good morning, Mr. David.
Good morning, sir.
How are you today?
I'm fine, and you?
I'm good. Please go ahead.
Yes. There is a... hello?
Well, we too. We can hear you loud and clear.
Yes. There is something I always feel. If I climb a step, very high step in the sun, I'll be breathing so high.
You'll be gasping for breath.
Hello?
Yes, we can hear you.
If I climb a step, very high step in the sun, I will start breathing high, very high in the sun. Until I came down the sun. Then I started feeling somehow normal, somehow in the sun. That's question number one.
Okay, go ahead with question number two.
Number two, what happened to a child of 11 years old boy, you understand? That started growing small white hair. Is anything wrong? Sorry, please. This one is not in connection to the health matter, but I just step in, please.
Okay. A child that is growing white hair early in life.
Yes.
Okay. Thank you very much. How old are you before you go, sir? What's your age?
I'm getting to 46 now.
Okay, you're getting to 46. Do you have hypertension, high blood pressure?
I don't have hypertension. But the fact is that if I climb a step, a very high step in the sun, like all these pedestrian bridge in the sun, if I come down, we'll be breathing so high in the sun.
When was the last time you measured? You had your BP measured? When was the last time your BP was taken?
Hello?
Yes, when was the last time you measured your BP?
I cannot lie to you. It's been long.
Okay. Doctor will start answering your question from that point. Thank you very much for those key questions. So we'll start with the first one. Much. Yeah, we appreciate you. Difficulty in breathing whenever he does some staircase.
Yes, thank you very much, Mr. David. I think, yes, based on the symptoms you've given us, you can't give any conclusive diagnosis at this stage.
Yes.
But what I would advise is you have a symptom which is significant, meaning when you are trying to climb the stairs or climb a bridge, you're having difficulty in breathing. That should not be. That's like you're having difficulty in breathing on exertion. So what our advice is you need to see your doctor as soon as possible so that they can ask you more questions and then do a comprehensive clinical examination for you. And if need be, would go on to do some basic investigation. Then, as you said, you are for 6 years and you said you've not checked your BP for... You can't remember when last you checked your BP. That's not good. Usually we advise from age 40 and above, you should check your BP as often as possible.
Yes, because some of these things, they show no symptoms.
Once in 6 months. So that's what I advise. You need to see your doctor as soon as possible to repeat these complaints, let them examine you, and then if need be, you do some basic tests. So
yeah, I agree with you, doctor. The picture he painted is that of somebody that is having a cardiovascular challenge. Yeah, that's why we were asking you questions around BP, hypertension. And let me reiterate at this point that some of these chronic illnesses like hypertension, oftentimes they show no symptoms. They can be asymptomatic. And of course, that is why it is called a silent killer. That was why I insisted. I wanted to know the last time you had your BP measured. That could actually be a clue to what you may be having, but obviously not asthma. Okay, because if it was asthma, you would have known. Now, your second question about a child, a 12-year-old, having gray hairs early in life, is it normal? Dr. Femi, what can you say on that?
Yes, I think for the issue of gray hair, that also has several risks or associated factors.
Okay.
Generally, yes, you won't expect a child or adolescent even to have gray hair. And in terms of development of gray hair, there are several related factors. There's the genetic factor, which most people don't even look at. We expect that before you can have gray hair, you should be at least maybe middle age to elderly age, but it's not necessarily so. There are some that are genetically predisposed to having gray hairs. It could be familial. Some could start having gray hairs as early as 30, 40. Yes, and there are some that it could be stress-related. But for that child that is 11 years having gray hair, number one, it depends on how much is the gray hair.
Sorry, let me pause you a little. Fashola, good morning.
Good morning, doctor.
Good morning, sir.
Well done, sir.
Yeah, pleased to have you, sir.
Please, I want to ask you about asthma. I did not have.
Okay.
But people are saying that if someone closer to cat, that person can get asthma. Is it true, sir?
If someone starts to do what, sir?
To close to cat.
Okay.
Yeah. That the hair of the asthma cat, if it enters someone's nose, that person can have asthma. Is it true?
Okay, thank you very much. I will allow Dr. Femi to take your question, sir.
Yeah, thank you, sir, for that question. Yes, household pets like cats, dogs, they are forced. They do not cause asthma, but they could be trigger factors for those who have asthma. So it's not as if they are the cause, like the fall of a cat, the fall of household pests. They don't cause, as in they are not the causative agents. However, we've talked about the risk factors. One common risk factor is usually household mites, animal danders, and animal foreskin. They are risk factors, meaning they could trigger those symptoms in those who already are asthmatic. So that's different. So it's not as if they are the cause. They are trigger factors. So if you are not asthmatic, even if you inhale fur of a cat, you won't have asthma symptoms. But for somebody who is asthmatic and is exposed to that and reacts to such, yes, it can trigger the symptoms. So it's not a cause. It could be a trigger factor for those who are predisposed to having asthma.
Thank you very much. Still talking about triggers, oftentimes there are some foods that we eat that could also be triggers for asthma. It would be nice for you to mention some of these foods, sir.
Okay, yes. Very apt also. Yeah, thank you for that. There are some food that generally people could react to. The first thing I want to clarify is that, as I said before, asthma is management is individualized. So the truth is that most food substances, because they are made from chemicals, could form triggers for asthma. But what I'll just say is, from my experience and from documented experience, there are some common food substances that patients that could serve as trigger factor. But the basic is that any particular food substances, once it's made from chemical, could serve as a trigger factor for asthma. But commonly, what we have is usually flavored food substances, flavored drinks. For example, some people react to vanilla flavor. Some people react to other form of flavor. So usually flavored drinks could serve as trigger factors. And also, people could react to some particular flavors of food substances. Some will react to fried food. So it depends. So what we usually advise is know what you react to and then try and avoid them. So most times, even as doctors, we may not be able to identify those trigger factors, but we would counsel you and tell you this is how you can identify it. So when you identify it, then you now revert back to your doctor, and then you can know it, and then you can avoid such.
Polycarp from Plateau. Good morning, sir.
Good morning.
How are you today?
I'm fine.
Yeah. Please go ahead.
I'm hearing you talking about VP. High blood pressure.
Yes.
Yes. So, me personally, I went to the hospital yesterday and test me and take my VP. I have never got that kind of VP before. I just give me a 140/90.
Yes, I'm with you.
Yes, 140/90. So please, you should put me through.
Thank you very much. Yes.
Yeah.
Mr. Polycarp was in. How old are you, sir?
I'm 46.
Okay, 46. Thank you very much.
Yeah.
He was in the hospital yesterday, and of course his BP was taken. The result was 140/90. What can we tell him, doc?
Okay, thank you, Mr. Polycarp. Yes, 140/90. As I will say again, we have limited information. You know, as physicians, I actually tell patients we are not magicians. We act based on the information you give us. So from this you've given us, it's not all-encompassing. But ideally, we know when we're talking of classification, once an individual's BP, especially above 40 years, is at 140/90, we start thinking in this aspect of could this be hypertension? And usually for hypertension, for a diagnosis to be made, usually we usually want to do a BP repeated over a period of time.
Yes.
So just one BP reading is ideally not enough to diagnose somebody as being hypertensive. Even if an individual comes in and it has 200/100 or 120, just at the sitting, that is not enough to make the person hypertensive because there are other factors that could make the BP go up just transiently. So for you, what our advice is, you need to, if this is the first time that you are noticing that kind of BP rise, 140/90, which on its own, yes, could be significant, but you need to go back for a repeat check. So when it becomes repeated, I mean, second reading, third reading, at different intervals, then I'm sure your doctor will know that, yes, this could be something that could be a pointer to hypertension. But just one single reading is not enough.
Thank you very much. Thank you very much. Now, for asthma, yes. Before I ask my next question, let's proceed on a short break. We'll be right back. Dr. Femi, once again, I appreciate you. Okay, so my first question, yes, at this stage will be, are women at higher risk of asthma attacks? If true, at what age are they of higher risk of asthma attacks than males? I also came across an article that said more asthma deaths among women. Is this true, and what could be behind that? Thank you very much.
Yes, thank you very much for that question. Yes, as you said, yes, studies have shown that there are variations in terms of asthma prevalence according to the gender, and this usually varies across the age group. So generally, studies have shown that in the childhood age, asthma prevalence is commoner in the male gender. So in less than 12 years downwards, asthma is usually more prevalent in boys compared to girls. However, once we enter adolescence and upward, we find that the trajectory changes. Usually from adolescents, we now have more prevalence of asthma among females compared to males, and this continues usually till elderly age. So usually in the elderly population, you have more women having more prevalence of asthma compared to men. There have been studies that have tried to look at what could be the possible causes of this. Some of these studies are not 100% conclusive. But some of the factors that have been found is that some have postulated that it's likely due to the hormonal changes in women, which usually starts around the adolescent ages and continues to after menopause, could be one of the strong factors that's responsible for this increased prevalence in asthma management. Then in terms of the deaths, asthma deaths being more among women, depending on the environment, especially maybe in this environment, developing countries, some have attributed that to the fact that generally males, that's men, generally have more access to health care system earlier than females. So females would most times not necessarily have early access to healthcare intervention compared to males. So that could be one of the causes of the fact that, yes, asthma mortality or death cases could be more in females compared to male. But I said, these are studies, some of them are not conclusive, but these are some patterns that have been noticed generally.
Thank you very much. Thank you very much for those wonderful answers. Now, my next question will be a practical one. Now, this is for people who are affected by this disease. If somebody is having an attack, what can you advise the person to do? At least in our environment, we may not have the luxury of punching a number and in another 1 or 2 minutes an ambulance pulls over at your door. Lanre from Abuja. Good morning, sir.
Good morning.
Yeah, how are you today?
Fine, sir. Please, I wouldn't want them to stop talking about gray hair, early gray hair.
Okay.
That what normally causes it.
Okay, thank you very much. Okay, early gray hair from Lanre. Okay, we've talked about it before. Okay, so just do a recap.
Yes, I said earlier, early gray hair, the causes vary. Usually it could be genetic, it could be stress-related, and it could be age-related. So depending. But however, across these 3 possible areas, either genetic, stress-related, or age-related, is not usually expected in a child of 11 years or less, like the earlier speaker asked. So depending, usually if it occurs so early as at that early age in a child, then you may need to go to see your doctor for further investigation. But generally, usually from anything from adulthood, that's above 20 years and above, it could be either genetic, either work-related, stress-related, or age-related.
Thank you very much. So somebody is having an asthmatic attack in one village and can't access hospital as quickly as possible. What can the person be advised to? What can you advise that such an individual should do, at least before getting help?
Okay. Yeah, thank you very much. So, as you said, depending on the setting, if, yes.
And also, are there drugs that those people should have handy or keep with them in and around their environment, cars, offices, and homes?
So, as I said, it depends on the setting. So, for those who are already diagnosed asthmatic, somebody who is already asthmatic, we have the reliever medication that they must always have. So, one thing before I go on, I want to demystify the myth. There's this myth that people who have perception generally, usually in the populace, and even some healthcare professionals still have it, in terms of they believe that asthma patients who are on inhaler, it shows the severity of the asthma, meaning that they will prefer patients generally will prefer to be on oral medications for the asthma, hoping that once they will need inhaler, it shows the asthma is not well controlled or it shows the asthma is severe. This is not true. The main thrust of management of asthma now, globally, is the use of inhaler medications, because science has shown that these are devices that deliver the medications needed to control asthma effectively with the least form of side effects. So our viewers should know that anyone who is asthmatic, the best way to manage is to be on inhaler therapy. And there are different types of inhaler therapy. We're not talking about that now. So for someone who has an asthma attack, depending on the location, the first thing is, if the person has his or her inhaler medication around, especially the reliever one, that should be looked for initially.
What are the two types? The reliever ones, the preventer ones?
Okay, so yes, the inhaler medications, we have the relievers and we have the controllers. The controllers are the same thing as the preventers.
Okay.
So the relievers are the ones that you don't need to use every day. You just keep them in case the individual is exposed to any trigger factor, meaning the person has an attack. So attack is something that you don't prepare for. Attack, the person is having sudden difficulty in breathing, affecting, and it becomes significant. Yes, at that time, the person needs the reliever medication. That would help to stop the difficulty in breathing and help the person to, as in, come back to normal state. However, for patients with asthma, what we recommend is, apart from just having that reliever, which you could use when there is attack, which is not planned for, the controller medication is very key. That's the preventer, because that is the goal of management. Now, we've talked about the fact that asthma is not curable. But however, people can live their normal life all through their lifetime without even having symptoms of asthma. And this can only be achieved when asthma is well controlled. And asthma can only be well controlled when individuals who are asthmatic are on regular controller medications. So for patients who have been diagnosed as asthma and who have been placed on their controller medication, they need to use their medications daily. So once they use this daily, then they are less likely to need reliever medication. So reliever medication is when the reliever is exposed to some factors that he or she didn't plan for. Yes. So usually the reliever medication, the commonest in the environment is the Ventolins of this world that you need to carry around. It's because in case of any attack that is not planned for. However, for the controller medications, you don't need to carry them around. You have them in your house, use them in the morning depending on the dose, or at night. So that one keeps the person away from any form of asthma symptoms. And studies have shown that patients who are adherent to their controller inhaler medication would hardly need to use the reliever medication, because the controller medication would control the symptoms in such a way that you won't need to use the Ventolin regularly. In interaction with patients, we see that you ask patients that you're on asthma medication, yes, so you're on inhaler. Which inhaler are you using? They'll tell you Ventolin. Ventolin alone cannot be your medication for controlling asthma, because Ventolin is just to relieve attacks. And for every asthma patient, we don't wish you have attacks. Asthma patients can live several years without a single episode of attack. And even when we're looking at the level of control.
And oftentimes, that is why they say it could be outgrown.
Yes. So the fact that an asthmatic, somebody with asthma has lived for 20 years without an attack, it doesn't mean the asthma has been outgrown. It just means that the asthma has been well controlled, and which is the goal of management.
Or the person may be having mild asthma too.
Yes. So, which is the goal of management. So for patients who are placed on medication, they should use their medication regularly, and they should be on control. Especially, so this you've raised now, I don't want to go too deep into it, so this course won't be too academic because our viewers are not all doctors. So as you said before, yes, that asthma can also be categorized into what we call intermittent and persistent. I don't want to go too much so that it won't confuse our audience. Yes. Intermittent are those that actually will not need daily medication. And studies have shown, even in our environment, that people with intermittent asthma are very few. They are less than 10% of the population. So if you see 10% with asthma, at least 8 to 9 of them would not have intermittent asthma, meaning they will have the other category, which is persistent asthma. And for everyone with persistent asthma, you need to be on your medication every day. So for those that will say they only need the medication every day, they are very few of the population, 1 out of 10. So most times when you see patients with asthma, they are in the persistent asthma category. Those that will need medications on a daily basis. And as we said now, the best way to control asthma is not to be on tablets, either Ventolin tablets, any form of tablet medication. That does not give the best level of medication and doesn't help to achieve control. However, inhaler medications have been proven worldwide and even in our environment to deliver the medications, to deliver the medicines effectively and to ensure control. And as I said, it's not just to be on inhaler medication. Being on Ventolin is not the way to control asthma. Medications like Ventolin or other reliever medication are meant to relieve any form of attack when the attack occurs. However, for patients with asthma, they are meant to be well controlled. So they are meant to be on controller medications, which your physician would prescribe to you and which you will be using on a daily basis, depending on frequency.
Thank you very much. Some of these medications, prolonged use of them oftentimes will make them to gain weight. I've seen that in a number of children. And oftentimes they may start developing some other side effects that will may come with long use of corticosteroids. What's your take on that? And what would be advice for people who have such challenges or their children are facing such challenges?
Yes, thank you very much. Very apt question. I don't want to go into depth in that because that question actually is more of a question among health practitioners. Yes, but it's good our audience can know about it. The truth is, as I said before, the way to go in asthma management globally now is the use of inhaled medications, yes, which basically usually inhaled corticosteroid plus or minus some other medications. And studies have shown that, yes, before now, decades ago, the fear was that because of the use of corticosteroids generally, corticosteroids have side effects, yes. But however, science has helped us to be able to overcome that in the sense that most of the side effects of corticosteroids come from corticosteroids that are taken orally. For example, as I said, because oral medications are easier to take, patients will prefer to take prednisolone for asthma management, feeling that it's easier to take. Those are the patients that would come down with the side effects of corticosteroids because prednisolone taking would go into the blood system. However, patients who are on corticosteroids that are inhaled, studies have shown that the inhaled medication, over 99% of those medications goes straight to the lungs and less than 1% goes to the blood system. So the fear of the corticosteroid side effect is very minimal. And that's why they can use that medication for a long period of time, for their lifetime, because they are not exposed to the side effect of corticosteroids significantly. Because the corticosteroid is not getting to the bloodstream. But for those who prefer to use medications, oral medications, the prednisone of this world, to be controlling their asthma, then they are the ones that increase risk of the corticosteroid side effect. So for those who are on inhaled medications that is corticosteroid-based, the risk of side effect is very minimal. And these have been documented in different publications, and we keep on having research that is showing it. And that's why GINA, which is the Global Initiative for Asthma, that coordinates in terms of recommendations for asthma management globally, which also affects our environment, which physicians in Nigeria also adopt, has recommended that inhaled corticosteroid is the way to go because it gives the medication just to the lungs. And the fear of side effects of corticosteroid is very minimal or even nil.
Thank you very much. Exercise-induced asthma, what can you say on that?
Yes, that's another concept in asthma management, exercise-induced asthma. So basically what this just means is that it's the occurrence of asthma symptoms in patients who are asthmatic who undergo exercise. So exercise-induced asthma would only occur in people who are already asthmatic. There's what we call exercise-induced bronchoconstriction. That one is when an individual who is not asthmatic undergoes exercise and has difficulty in breathing. That is possible. If somebody who is not asthmatic undergoes a strenuous form of exercise, he could have difficulty in breathing. And you could think, this person is asthmatic. No. But however, for an asthmatic, depending on level of control, exercise, they can exercise, but the exercise will be graded based on a level of control. For somebody who is well controlled,
Thank you very much.
the person can do some form of
So
exercise.
sorry I have to stop you.
Yeah,
I'm
thank
afraid this is how much time will allow us today. But I promise you we'll be back with the same topic next week.